on the scene. I can't give you what you want, but you got to go home with me. And I've got some good old love, and I got something so, and I get to throw it on you. You gotta come back for more. Come on, the boys will come down by the nothing. That ain't nothing but just as love. Little thing, let me light your candle, 'cause mama, I'm so hard to handle, oh, darling. Yes, I am. I'm so hard to handle, baby. All right now, come on, come on. Oh, now come now, give it to me. I'm hard to handle. Give it to me. I'm hard to handle. One time, come on now, give it to me. I'm hard to handle. Hey, give it to me. Give it to me. Give it to me all the time. Oh, hey. Let me light your candle, 'cause mama, I'm so hard to handle, oh baby. Oh darling, come on, the soul music, yeah. Play now, play now, it's music. Thank you so much, everybody. Thank you so much for having us. To the wonderful Alzheimer Congress for having us. We're gonna do a last song.
Yeah.
Positivity. One more time. So everybody, hope you enjoyed the music today. The last song is called Positivity. Positivity.
Wonderful. Thank you so much. And I'm afraid that we are going to have to say goodbye to you now.
Thank you guys for having us.
Yes. We put the links of your Spotify on Twitter. So if you follow me, then you can find more of it. Stefan Morrison, Stefan Geuzenbroek, always bringing us wonderful musicians. Good job again. Yeah. And Alvin Lewis. And do you have your glasses back now? That was really funny. Did you see that? So how did you like the audience there in the camera? Yes? Yeah, there, over there. Yeah. Thanks so much.
Thank you for having us. Appreciate it.
11 people are telling us, oh, wow, great music. They've been doing that all day long. Yeah, we loved it. And you...
Did you notice as well that it's at that time when you started singing about positivity that we had the first bit of Blue Sky?
Yes.
Yes. You
to illustrate
something right.
It was synced with that.
We produced that so that it would look nice. Thank you so much. And you won't be able to miss them anymore, right? You want them to wake you up.
It's a real shame I could do with that every morning.
Yes, me too. And afternoon and night. Well, yeah, sure. So thank you so much for all the compliments for the music. Wow, that really was great. Malta, I think that now everything works again. If you refresh your link, it's supposed to work again. Great music, wonderful. Positivity, that's all it takes. Well, people are warmed up to the final part of our conference.
It almost seems incredible that this is the end of our conference already, or at least, well, we have one session still to go.
Yeah.
But it's very close to the end.
Yeah. Time flies then when you're having fun. That's really true, right?
Yeah, and I think people enjoyed it as well. Like Twitter was busy, people interacted with us over the platform. We had 666 participants, so
that is a strange number. What does it say about you guys? I don't know really. We're gonna ask you a few poll questions, so take a look already if you want. So then we can talk about that a little. But first. Twitter was very active.
Yes.
Yes.
And I think we have our final stats now for the day.
Yeah.
So how many people tweeted about AlzheimerEurope? So you see that we had 4,644 tweets.
Wow.
Which is quite impressive.
It is.
And all of these tweets together garnered 19,300,000 impressions. That's not 19 million different people.
No.
But it's people that saw the tweet, that liked the tweet, that clicked on photos, that clicked on link, that retweeted something. But 19 million impressions, I think we can be very happy
wonderful. It's really
with that
good
outcome.
for the public relations, for people getting to know the subject and what AlzheimerEurope does, right?
And really also, as you can see from the slide, the topics and what moved people really is people with dementia speaking about how they coped with the pandemic, how they dealt with the pandemic. So we have a lot of really positive feedback about Patrick's presentation from this morning, Kevin's from the first day. So that's really what people seem to have liked the most at our conference.
Yes, there was one particular tweet today that I really loved that was not about being moved. Well, in a way, was somebody who said, I don't have a pet, I'm not able to compete, but I do have a knitting work.
Yeah, I thought that was an interesting link. I don't have a pet, but I do knit, so yes.
No, it's fluffy also,
yes,
you know?
That's true.
She put that in front of the camera and in front of the computer, and I thought that was very funny. And what else did you see?
And I'm sure that if you look at the second slide of our tweet impressions, that I'm sure people are very interested in the kind of statistics.
Yes.
We did say that we would provide an award to the most influential tweeter of our conference.
Is this the moment that it's going to happen?
It is absolutely, and now it's the moment. So
pay attention.
The slide is on, and you can see the kind of results.
Yes.
It comes to the top 10 influential tweets. The top one was AlzheimerEurope itself.
Of course.
And also my staff was incredibly busy, so of course we're not going to give an award to come to the conference to somebody that's anyway going to be there.
They'll be there, yeah.
But we noticed that the first top influencer that is not a member of AlzheimerEurope or our European working group is a group called Distinct Dementia. And it's a network, it's a project actually coordinated by the Interdem network. And it's a network of early stage researchers. And since we don't want to pick just one of those early stage researchers who could come to Bucharest, but we thought could be really nice, we give them the opportunity to have a symposium at our conference, and we will bring 5 of the early stage researchers of the Distinct Network to Bucharest, all expenses paid by AlzheimerEurope, travel expenses and accommodation expenses, so that they can share the fantastic work that they're doing and really be a part of our conference.
The winner again, Distinct Dementia.
And as you can hear, Marjolein de Vugt, who's in the studio as well, she's the chairperson of Interdem, and of course is very happy about that award.
So again, the account was Distinct Dementia?
Distinct Dementia. It's a project,
congratulations. You really did well, so it really pays off to be an active tweeter, right?
Absolutely.
Wonderful.
So, yes. And here is just a few, you can see a few of the tweets they made. They commented on a lot of the kind of presentations, keynote presentations.
Yep.
They also commented on some of the kind of fun part. They commented on the cooking yesterday. They laughed about the fact that when I asked how long do you boil potatoes for as long until they're done.
Yeah.
They thought that was
how
very
long till
funny.
they're done? Until they're done. Yeah, good one.
And so they tweeted about yoga and different things. So they've been very active both on serious subjects, but also on the more fun parts of the conference.
Like the conferences.
Yes.
Good, that's great. So, and of course you've been very active as well in the polls. And here in the Q&A section, when you click the button Ask, please tell us everything you still want us to know. You can comment, or you can ask your final questions. You can debate with us still a little, or just tell us what you thought, whatever. So please keep that going. And you could put your name in the end of the comment if you want, because then we know who you are. But first, let's ask them a serious question.
Yeah, because the next session that we're actually having is, we focus at this conference really about the effect of the pandemic.
Yeah.
And what we really wanted to focus on in the kind of final session is, let's hope that this pandemic will be behind us hopefully soon.
Yes.
But then what should be the priorities of our movement? How can we improve the situation of people with dementia? How can we have fewer people prevent dementia better?
Yep.
How can we treat it better? How can we care for people better? So all of these questions that we wanted to hear from the audience, what would their priorities be?
Yeah.
So, and that might be a good start actually, before we meeting our speakers. What do our audience feel should be the kind of top priorities?
Yeah, what should be our post-pandemic research and policy priorities is the question. And if you didn't vote yet, please do that now, and then we will see the votes and the results changing. And of course, that's interesting for the speakers that will be with us to hear also. So let's see.
But
for now,
unsurprisingly, I think for us, I think the top priority for the group that is attending our conference is really improving the care and support of people with dementia.
Yeah.
After that, you have better supporting carers, but also promoting brain health. You have improving timely diagnosis, making societies more dementia-friendly, combating stigma. Actually, all of them seem to be similarly high priorities. So it's going to be an interesting discussion, because we're going to ask our speakers, well, what do they believe should be the priorities for us in the future?
It fits with what we discussed earlier today. There are so many priorities. Really lots of work to do, right?
Yeah, I think we can have quite a few more AlzheimerEurope conferences, because this is not a job that will be done anytime soon.
No. And by the way, you look nice. You changed.
I thought, well, on advice from our
production
I thought
team.
it might be a bit more informal for the end.
For the end.
We've done a lot of formal work, and now we can hopefully after the conference relax a bit as well.
It's very professional to change for another part of a program. So wonderful. I'd say let's go and meet our speakers.
That's good.
Yes, we're back, and we're at the table for the last time at this table. So we've invited 3 speakers to comment on the conference and on future. So who do we have here?
So we have 3 excellent speakers. We have Professor Craig Ritchie. He's from the University of Edinburgh, and he's really well known to a lot of the speakers and participants of AlzheimerEurope conferences, because he coordinated the EPAD project, but currently is also involved in the Centre for Dementia Prevention and Brain Health Scotland.
Yep.
So great to have you here, Craig. Our next speaker after him will be Lutz Frölich.
We wanted to say hello. Hi, Craig.
Hi, everyone.
Hi, hello, Lutz.
Hi, Jean.
Wonderful.
And so our second speaker is Lutz Frölich. He is from the Central Institute for Mental Health in Mannheim, but he's also the chairperson or co-chairperson of the European Alzheimer's Disease Consortium, also a network of clinical centers with whom we have a very close collaboration. And then here in the studio, we're very happy to have Marjolein de Vugt. She is professor from Maastricht University. She's also the co-director of the center, Alzheimer's Center in Limburg. And of course, she's now, as of the beginning of our conference, she's the chairperson of the Interdem network. So she was particularly happy that the Distinct project won this award from the conference.
Yes, she was happy. She was jumping around. And we've heard you, and we've seen you 2 days ago. The time flies, really. So how well do you know each other? Anyone?
Yeah,
I know Lutz pretty well. We go back a long way in terms of collaboration. So
Okay, and
yes.
you
And
Lutz?
of course, the Maastricht Center is all well known to all of us so well. You know?
Yeah, maybe not in person, but you do know each other's institutions.
Yes.
Yes. Wonderful. Welcome.
So as I said, we've thought what we wanted to do here is really talking about looking back at the pandemic and looking forward for once. What should be the priorities for our movement? What should be asking politicians to really invest funding in? And I thought we had 3 speakers that could give slightly different pitches to us, because we could maybe start with Craig and talk about the importance of stopping people from getting dementia and seeing how we can promote brain health in Europe. But over to you, Craig.
Well, thanks so much, Jean and Kim, and congratulations on a brilliant 3 days. It's been absolutely amazing, and such a pity, as you know, Jean, I couldn't actually physically be with you. We had to cancel that on Saturday, I think, because of the changes in the travel regulations. So that's a heartbreaking. Couldn't be with you today. So sorry for that. And I guess it highlights the fact that, you said looking back on the pandemic and what the future is. We're still in the pandemic, aren't we? I mean, we're not quite through it yet. But let's hope that 2022 is very different to 2021 and 2020. Reinventing dementia care and treatment. I think the first 2 words in that title is probably the most important. That's reinventing dementia. I think for numerous, and by the way, I don't have any slides. I'm just going to talk.
Yeah.
For the last, 110 years, we've really had to think about dementia through seeing patients, if you like, or seeing people at the very, very late stages of the diseases that lead to dementia. Necessarily, perhaps mainly older people who've got quite pronounced symptoms, both cognitive and behavioural, as well as functional impairment. And I think projects like EPAD, which obviously AlzheimerEurope played a pivotal part in, have really, in the last 10 years, helped us understand that diseases that lead to dementia start at least in midlife, if not even earlier. That research and projects like Prevent Dementia have really highlighted the fact that the Alzheimer's disease in particular, if you like, as an example, is a brain disease that has cognitive symptoms rather than a cognitive disorder. And knowing that these diseases start in midlife, I think gives us a huge opportunity to identify or detect these diseases as early as possible. And as with every other disease in medicine, if you like, the earlier you detect something, the better the prognosis, because you can intervene, you can manage the disease. So I think we have to reinvent in a sense what we mean by Alzheimer's disease, and recognize that dementia is a late-stage consequence of a midlife, a disease that starts in midlife. And if we do that, and we are doing that, and that's what we're, as you know, Jean, we have pitched this to the politicians in Scotland 3 or 4 years ago. Myself and Henry Simmons, who many will know as Chief Executive of Alzheimer Scotland, had a meeting with the First Minister, Nicola Sturgeon, and we pitched exactly what I've just said, that if we can identify people that early in the course of the disease, then we will have every opportunity to prevent dementia. But we have to nest that sort of, if you like, that detection of the individual in amongst what we call our sort of brain health ecosystem. And that is that you don't just work with the individual identifying early disease, but you also want to work with the population as a whole to see if you can maybe prevent the onset of the risk factors that lead to these brain diseases. So that's where you're pitching, not just for new clinics and new ways of thinking in terms of early detection, but you're also thinking about, well, how can you get into the public? How can you get into the policy arena to make a difference to risk factors? So on the one hand, at Brain Health Scotland, we've got this incredible amount of work we're doing with NHS Scotland to set up clinical services. But equally important, we've got an education lead who's looking at a primary schools programme to look at those risk factors for dementia that are so clearly articulated in the Lancet Commission report, and see, can we set the tone of life in a school child, either at primary or elementary school or secondary school, that means that they won't drink as much alcohol, they won't smoke as much, they won't have the risk of developing diabetes. So primary prevention at that educational level, working in the workplaces, and secondary prevention with people we identify 20, 30 years before they have symptoms. So the vision for the future is, I think, fundamental change in the way we think about Alzheimer's disease And to do that, I think we have to really have a fresh start in terms of public health policy and clinical care. So thank you.
Thanks. Quite clear, huh?
Yep, and I think also it echoes quite nicely because we had Jill Livingston here, and so she discussed some of the kind of risk factors and also presented the kind of findings of the Lancet Commission. But interestingly enough, like some of the kind of key risk factors that she felt that we should be working on is hearing loss, for example, and she really said that that was one of the key ones, and almost one of the most important ones. How would you see that? Just how would that fit with your kind of brain health promotion?
Well, I think obviously we love the Lancet Commission report. We use it, and we think it's a really nice, cool way to be able to communicate these modifiable risk factors. But I think there's two things that we think about. I mean, number one is that, and this is maybe slightly technical, but all the epidemiological studies that were in the Lancet Commission report were about the risk of dementia, the dementia syndrome. Now, it may be, and we're finding this with EPAD and with PREVENT data, that some of the risk factors for accumulation of amyloid or cerebral blood flow are not necessarily the same as for the dementia syndrome, okay? So if we're looking at primary prevention very early in life, if you're talking to school children, you're not necessarily going to prioritize hearing loss. There's something to avoid.
No, just from 45 on, right? Something like that.
Yeah. So I think there is that life course kind of interaction, like you say. But the second thing, and I think this is really, really important, is those 12 risk factors were, and I know this audience will understand this, they're what were called the population attributable fraction, the PAF. So they became important because not only the strength of the risk factor, but how frequent that risk factor was in the population. So it's 1 times the other equals the answer. Most of the studies that went into that were in North America, Europe, and Australasia. Mm-hmm. So if the risk factor is more or less prevalent, say in sub-Saharan Africa or in Southeast Asia, you get a completely different result. And I think what we need to do is we need to look at, and I know the Davos Alzheimer's Collaborative is trying to do this, is we need to look at cohort studies and data from other parts of the world to see if the same story is true when we move out of Europe, Australia, and North America.
Thanks. Yes. Okay.
Yeah. So I think we heard
later. Yeah.
I think we heard from Craig really about the importance of preventing people from getting Alzheimer's disease, and I think our next speaker would be Lutz. And what happens to people that get to the MCI stage or to the early Alzheimer's dementia stage, and how are we seeing kind of the treatment of these people and the medical treatment in the coming years?
Yes.
Yes, thanks for the introduction, John. Actually, within my statement, I have had a sentence with the same phrases as Craig has used.
That's a good thing.
So I wrote in my abstract, the application of these new treatments require a fundamental change in the approach to diagnosis and conductance of treatment. Mm-hmm. So I think this is a statement which applies on the conceptualization of Alzheimer's disease and the other neurodegenerative disorders in a whole. And it's really important to see that so much of scientific evidence has been generated to now, and the question is now how to apply this into clinical practice from my medical standpoint. Yeah, I mean, my major view on the situation with Alzheimer's disease comes from this new treatment. In June this year, a new molecular treatment for Alzheimer's disease has been approved by the Food and Drug Administration in the United States, not in Europe, which is important to note. Yeah? And this is a monoclonal antibody. This aducanumab is an anti-amyloid antibody, which targets this basic proteinopathy, which is in the sort of the heart of the medical pathophysiological understanding on Alzheimer's disease. So the amyloid mismetabolism is perceived or is believed or can be shown to be more or less the starting point for the disease process. So amyloid peptides are being generated and deposited into amyloid plaques, and in a complicated process, this in turn sets downstream effects on the aggregation of tau proteins, which lead to these Alzheimer tangles and so on. So a complicated pathophysiology starts, but it is very interesting that in the center of this, or in the beginning of this, you have pharmacological targets with this antibodies which work against this amyloid mismetabolism. And due to this mechanism of action, these new treatments, these molecular antibodies, are seen as disease-modifying treatments. So they don't really merely improve or ameliorate symptoms as the anti-dementia drugs, but it is highly likely, and has been shown to part of it, that it really changes the biological process of the disease. So this may, over the long run, exert really important clinical differences.
Yeah.
However, I mean, the diagnostic process required for seeing patient eligible for these new treatments, if they were available in Europe, is really quite complex. There is the senses you need to prove that with sensitive neuropsychological testing, that the patients really meet the early stage of Alzheimer's disease. And this is the most important one, with biomarker testing, you need to prove that the patients have amyloid pathology in their brain, so that this treatment works at all. Yeah. And you can hear from that the diagnostic process is really complex and also burdensome for patients. And it requires a lot of time and competence on the physicians. And also the treatment is different from simply applying a tablet, also giving out tablets, but it most likely will be IV infusions or subcutaneous infusions or applications of the drug over repetitive cycles. And then the treatment needs to be monitored with high sensitivity and technical investigations like MRI, that there are no dangerous side effects showing up in the brain. And the whole process, of course, can only be started and should only be started. And this has been part of our, what we presented with the aid of Christian Steen-Fredriksson here at the conference, that you really need a detailed counseling and advising and informed consent from patients. And those patients are able to follow what is going on. Yeah. So you need an informed consent that you want to start these biomarker investigations. You want to have shared decision-making with the patients, what to actually do or not to do over the process of diagnosis. And only a subset of the patients who come with this condition of mild cognitive impairment will be eligible for the new treatment. And they need to be informed what can be expected, of course, and how to do this long-term treatment. Many things are still unclear. How long will these infusions be applied? Will you stop the treatment, or how you will fade out with the treatment at some point in time? Because improvements of the condition are not what is going to happen, but it's an amelioration of the course, actually. And the application of repetitive MRIs is also a problem. And patients who do not have these positive biomarkers, they also need help and advice. Yeah? You cannot simply send them home and say, you're not eligible. This is a medical task in itself. Yep. It sounds complex, and it is complex. Maybe if you want to have a look at this one slide, I'm not quite sure if there's enough time for this still. I have 3 minutes or so. If you show the slide, which is already up, then you will see sort of our vision on the management of Alzheimer's disease. Is that on now?
No, you have to still have to share. Can you please share that?
No, it is. Supposedly I have shared already, and they said they just have to bring it in somehow. But if not,
sorry, maybe you have to describe what's on it.
It's okay.
Yeah.
It is okay, because the complexity will only be demonstrated by a complicated medical slide in a way. So it's unclear if this antibody will be available in Europe because of severe shortcomings in the methodology of the trials, and it's not quite clear if this can be accredited by the European Medicines Agency at all at this stage. However, there are several other antibodies in the a similar stage of development, and in the next couple of years, they will come to an end with their clinical trials, and it's likely that one or several of those might be approved as for treatment as well. So the time is really pressing in a way, because the required changes in the medical system will be quite dramatic because of these biomarker assessments, because of potential screening assessments, and it's quite unclear where and how to apply these infusion, maybe in specialized centers and so on. This all requires new ways of cooperation from primary care physicians, who should be involved in the process of early identification, in medical expert centers who have so far the tools and the competence to perform this neuropsychological testing, and also the biomarker testing, which are not frequently done so far. And then we still have the problem of how to handle the considerable amount of patients who will be in need of that patient, who might profit from that treatment, actually. So this is a story which is more or less at the beginning, I believe, although the medical evidence and the scientific evidence has been accumulating a lot. And I think this advancement in the understanding when is the critical point in the disease process, when to identify patients and inform them about the options they have, is really changing. But the understanding in the medical system, at the present medical system, is still restricted to helping patients with dementia. And this is not the timing that should be applied for these new treatments. So it will be, many things will need to happen in the upcoming years, and hopefully these treatments will shift, will make a shift in the options from the medical side for patients with Alzheimer's disease. So far, only Alzheimer's disease.
Yes, so far, exactly. So that's interesting. It sounds like there's progress. It's almost exciting.
Absolutely. I think Lutz sounds very positive.
Yeah.
And a question I would have, because around the kind of positive nature that you have, once a treatment is authorized by the European Medicines Agency and by the kind of different national systems, how much time do you think before the systems are really ready to start diagnosing people, putting all of these kind of treatments in place? Because you mentioned that there's a lot of other things that need to be developed before we can really fully roll out such a new treatment.
Yeah, you're absolutely right. I mean, when we think back these 20 or so years, at the time when the anti-dementia cholinesterase inhibitors, the symptomatic drugs, were introduced, this was fairly rapidly, I would say, within a year or two, taken up to a certain extent. But until now, it's not really fully appreciated that all the patients who might benefit from these symptomatic drugs are really getting those drugs. So this story will be more complicated, I would say, And I'm not so sure that the system readiness is really easy to achieve. But still, I must say, you're right. I am positive for these new molecular treatments, although it is absolutely clear that the methodological shortcomings are great. And we will see and wait until shortly before December what the EMA says, if they accredit it or not. I think it's a bit unlikely here.
Another question I had, because you have a clear idea about what's happening with people with Alzheimer's disease, with amyloid pathology. How hopeful are you for better and new treatments for people with other dementias, for people with non-Alzheimer's disease dementia, with Lewy body dementia, frontotemporal dementia, and so on?
Well, I mean, scientific advancement is really a surprise sometimes. So really, this, I think, the most interesting part about science, the surprise. Of course, the understanding of, let's say, frontotemporal dementias, the tauopathies, and sort of pathobiology of other neurodegenerative dementia has advanced a lot on the molecular level. However, to identify pharmacological targets and also to see if these targets can really be handled by drugs is a complicated process. And Well, I am a bit more skeptical for diseases outside Alzheimer's disease that this will be achieved in the next decade or so.
Okay, well, that's a clear answer, less hopeful. But
you never know. Yeah,
no, exactly. We have to keep that open. We have more questions for you, but we do that later, all right? So I think that it's time for us to go to Marjolein. Yes.
Yeah, because also we heard now about the ideas around prevention, brain health. We talked about people, how we might better be able to treat people, especially people with Alzheimer's dementia or Alzheimer's disease. But we will always have people that we will need to care for. And Marjolein, what are your views about the importance of caring and supporting people at the dementia stage?
Yeah, I think I will leave my slides because I think it's good to speak from the heart in that sense. I think the key message in that is that it is really, really important to bring the right care to the right persons at the right time. And that is, I think, the big task for the next years to come. And that based on a human-centered approach instead of a disease-based approach, and also taking into account diversity aspects, as we so clearly also heard this morning about from several speakers. And so my opinion, there are three elements really, really important in achieving this. And that is that we make sure that our interventions are timely, that they are tailored to the needs and wishes of the person, and that they're also accessible in that sense. And taking the first element, looking at the timely interventions, I think it's not only about having a timely diagnosis. There's still also a lot to win in that, especially for specific groups such as people with young onset dementia. There's still a lot of delay in time until diagnosis. But also after diagnosis, there's still a big gap often between the diagnosis and post-diagnostic care. So there are some hurdles to take there, and that also is caused by also the acceptance of help and support in this early stage. And we call this the needs paradox, that people in this early stage often, to me also in the memory clinic, say to me, I don't need support yet, I will let you know when the time comes. But then later on, they realize that more timely support would have helped them to facilitate the acceptance process and to be better prepared for times to come. So I think in this sense, it is very important in this early stage to have a more positive way of fulfilling this post-diagnostic care, in that sense that a more focus on positive aspects helps them to accept also care and support in an early stage, focusing more on living with and preparing their life and looking at their lives in different ways and think about what they really find important, instead of thinking about and focusing on the loss that they experience. To achieve the second element, the tailoring of interventions, I think my main key message would there be, of course, the most important way of achieving that is working together with people with dementia and their carers. And I heard a lot about that during the conference, by involving them in designing our interventions and having a better idea of the needs they express. But in that sense, we don't need to reinvent the wheel, because we have a lot of very effective interventions, but that can be even be more effective if we take them as a starting point to tailor them to the needs of the specific target groups. For example, maybe you've heard about the intervention partner imbalance that we've developed, which supports caregivers of people with dementia in an early stage, taking a positive approach. We developed that for a general population of caregivers, and we found it effective in an RCT, but then there were also some challenges in the sense that young people, for example, did not really recognize themselves in this intervention. So we adapted that intervention to these more specific groups, for example, for carers of people with frontotemporal dementia. So we don't need to reinvent the wheel to better tailor our interventions. And then the third element, the accessibility of interventions, there's also a lot to win. Of course, this was challenged a lot during the last period of the pandemic, but it has also brought us, you could say, a digital revolution, where also healthcare professionals needed to change their work routines and needs to be creative and adopt new ways of supporting people with dementia and caregivers. So that also, gives a very good basis for bringing this further, and also to make sure that we strive for integration of digital and non-digital approaches to fit the needs of people with dementia and their carers. And of course, what is very important is that we do better in implementing our innovations in research into practice, and that's very important. For that is also collaborating together with all the stakeholders that are important to achieve that. So that would be my plea to bring the right care to the right person at the right time.
People are somebody entered the comment, and many people agree. Fantastic point, Marjolein, about the timely and appropriate care and support after diagnosis. So people really agree with you on that.
That's good to hear.
Yeah.
I'm just wondering, because listening to the kind of two presenters that talked before you, is there a road, for example, for biomarkers and an understanding of the underlying disease that causes dementia in the way that you care and support people with dementia? So can we bridge the parts which is around prevention, around treatment and biomarkers, and the aspect of caring for people with dementia?
Yes, I think that is also a very important point you make, to bridge this gap between the more biomedical approaches and the psychosocial approaches. I think especially in the work around prevention, that's really important. Also within the concept of social health, to understand better the brain mechanisms and to use also social concepts to improve the well-being of people before the stages of dementia, but also afterwards. So I think, it's a good point.
Craig is waving at you. Want to say something? You want to say something, and we have a question for you as well. Go ahead, please.
Sorry, I could see that you could see the TV screen, so I was just waving.
You can just talk.
I just wanted to make a quick comment, Jean, on your point. I don't think I don't think we should be dividing prevention into the biological and care of people with dementia into the psychosocial. I think biopsychosocial goes across the whole spectrum. In fact, many of the things that we'll be doing to try and prevent dementia, which is still early diagnosis of the disease, if you like, is going to be psychosocial. We're doing a lot of work about social prescribing. We're doing a lot of work with, behavioral psychologists and health psychologists about, risk factor modification. In fact, what we're doing in our brain health clinics is probably going to be a long way away yet until we have any medicines. So I think, I don't think it's a good idea to sort of partition the two.
No.
It's a continuum from early disease in which the dementia is a late stage. But the biopsychosocial model, I think, goes across all those stages within the continuum.
Okay, so I have a comment. Oh, can I please?
Maybe just elaborate on the social prescribing part, because not everybody might be familiar with that term. So what do you mean by social prescribing?
So I think there's a lot of very strong evidence around, well, let's take a great example. One of the things we've learned during this pandemic is the impact of social isolation on brain health and the risk of dementia and progression of dementia. So social prescribing may be, for instance, to enhance or encourage people to be more socially active through prescribing gym memberships, prescribing, visits to a museum or an art gallery or what have you. So in some ways, you could almost argue that social prescribing is non-pharmacological interventions in many ways. But I think the effectiveness of those interventions is either well proven or common sense. And I think if I'm advocating to policymakers or to budget holders within government, I don't want them to think that treatment just means drug treatment. Treatment has to include these psychosocial interventions as well.
Yeah. Okay. So there's a quick. Can I? Oh.
Yeah, there you go.
we were a good team before, but now we're in the end. We have to separate now. It's just a very short question because I just wonder what it came in way early about the hearing loss again. One more. You said, well, it's not that important in the schoolyard, but then she says, well, please do prioritize it because young people who spend hours with earphones on and they have hearing damage earlier. So.
Okay.
They wanted you to know. Okay.
I thought we were going to be told we weren't allowed to go to rock concerts anymore.
Exactly. That's prevention.
I think your point, Kim, was right. It might be that there's different priorities for different. I mean, you said it was 40 plus for hearing loss.
Yeah.
I think you need to be able to communicate to people. You need to meet people where they are.
Yeah.
And that's why we decided to call it Brain Health Scotland and not Dementia Prevention Scotland, because if you go to Dementia Prevention Scotland, you're not going to get away into primary school children. They're not going to see it as relevant.
Okay.
I think you have to have relevance for the audience you're speaking to. And hearing loss to a 7-year-old,
not that common. No, but it was a comment, not mine, but from the participants, and we really love it that you interfere here. So, but you first.
Maybe just also the question around brain health. In how far does it, because you go beyond Alzheimer's disease.
To whom?
Yeah.
So it's to Craig as well.
Okay.
So it goes beyond just brain health. It just goes beyond just Alzheimer's disease. What other diseases would you include as well in your kind of work and prevention work?
That's a great question. So we've had to think really hard about that. I mean, number one is we had early conversations with the mental health directorate in Scotland and made a clear partition between mental health and brain health. And brain health, as you can imagine, is about the health of the brain, whereas mental health was seen conceptually as a psychological disorders rather than necessarily brain diseases. Within that, we're more focused on neurodegenerative diseases and cerebrovascular disease than we are necessarily things on multiple sclerosis or brain tumors or what have you. But I think there needs to be, we've got this paper we've just published in Journal of Prevention of Alzheimer's Disease, where we have these red conditions, brain tumors, obviously not for us, amber conditions in the middle, green conditions is our sweet spot. But they do tend to focus on all the neurodegenerative diseases and cerebrovascular disease and also functional cognitive disorders, we think is within our purview as well.
Thanks a lot. For Lutz, we have a question here. Dear Dr. Frölich, it says, do you think that the field should be more positive about small steps and not expect miracles from a new drug? That's a wise comment, in a way.
Yes, of course. I mean, in a way, that's obvious. Yeah. I mean, the magic bullet, which will by itself change the whole understanding of the whole course of Alzheimer's disease will not be achieved. Yeah, and even these molecular treatments, these antibodies, the most that can be expected of them is a slowing down of the course over years, which is a lot. So still, this in these studies, this is a difference of 22% within. Against placebo course, against, let's say, the so-called natural cause of dementia. This sounds not much, but if that hold true and this will go on over the years later, then this might be a lot, but it will not be one magic bullet.
No magical drug. That's a pity, though. Yeah.
If there are no magic bullets, how do you communicate that to potential patients that come talk to you?
Yes, I think the whole process is very important. Yeah, the communication with patients and to see them as partners really in the process of handling the disease. Yeah, and this is the strong shift towards autonomous and self-competent people that you are talking to, and that you have to. Negotiate about what they want in the process and to achieve an informed consent and to make them aware of what can be expected and cannot be expected.
Yes, thank you so much.
Maybe to comment on that, I think with these developments, I think indeed shared decision making becomes more and more important. Yes. That people really understand what can be the consequences of knowing or not knowing something. Yeah.
And there it interlocks with your psychosocial treatments a lot. Yeah.
Yes. So thank you. There's one more also, Marjolein, maybe for all of you. What means improving social health from a community view to strengthen social cohesion with other professionals than only care? Who can comment? Marjolein.
I think especially social health lies outside of the care practice. It's about a whole society becoming,
of course,
more friendly. Also, the dementia-friendly society is very important to.
Is there a connection?
To include people with dementia and make them feel welcome and accepted. And what I experience a lot is that for people with dementia, still the outside world, so to say, is a world where they need to be a better version of themselves, hiding their mistakes, for example.
Like we all do.
Like we all do. But
like Craig doesn't know that he's on screen right now. Yeah, okay. Small.
I was thinking.
He was thinking like the thinker. Yeah, good. Making notes. Go on, Marjolein. Yes.
Yeah, so I think in terms of that, it's everyone who's involved in achieving social health for people with dementia.
But are there ways to improve that cohesion? Maybe, Lutz, yes?
And even, I mean, in particular with these new treatments, if they were or will be available, it is really important that subjects, I would say, elderly people who have sort of subtle changes in their brain, they are engaging in the process. Do I want to know more about this, or am I really developing symptoms of Alzheimer's disease? And will biological investigations help me to find out where I am in this process? So it sounds still a bit awkward, but sort of accepting that there may be changes in the brain, like in hypertension or in diabetes, and we have to learn to live with this, is a common thing.
Okay, yes, we understand. Just a comment for you. Great to hear that communication about expectations and shared decisions is being highlighted as crucial in future care and trials. Yeah, you agree.
And treatment.
And treatment, yes. Yes, that was the one missing, yeah.
I was also struck by the fact that a lot of people compare the field of Alzheimer's disease, for example, to heart disease. That everybody wants to know about their cholesterol levels, their hypertension levels, and once you know that, you can then potentially prevent heart disease or more serious consequences. And a lot of people talk about the Alzheimer's disease field in a bit similar way. Once you know a number of your risk factors, including amyloid, you should then also take some action. But in the Alzheimer's field, we've decided to call all these risk factors already Alzheimer's disease. And I'm just wondering, is that the best way of communicating that? Because by communicating to somebody that they may have preclinical Alzheimer's disease, that might pose a lot of concerns, whereas talking to somebody that their elevated amyloid might be a risk factor for developing Alzheimer's disease at a later stage, might be a different way of communicating that. I'm just wondering whether I could have
what do you think of
your thoughts about that.
Craig.
Yeah, well, I think we've a long way to go in terms of health literacy around all of these topics that we've been discussing. But I also think we've got to improve medical literacy. I think we have seen Alzheimer's pathology, amyloid pathology, as being the disease itself. But I think more and more we are learning it's a trigger for the disease rather than the driver of it. And I would like to see a future, I think, where we do have a blood test for amyloid and we use it and we frame it the same way as we have a blood test for cholesterol. And we have anti-cholesterol medications, which the public are quite happy to take because they know that by reducing cholesterol levels, and of course we can reduce cholesterol levels also through diet and exercise, that will have a downward impact on their risk of developing a heart attack or a stroke. So Alzheimer's, pathology, if you like, the amyloid pathology should be more like cholesterol is, and less like probably tauopathy, which is more like the disease itself. So I think we've got a long way to go to disentangle that and recommunicate it, I think, with the public, but also with our own colleagues.
Yes.
Yeah. I mean, we all couldn't agree more for this, and it's related a lot, I think, to stigma and taboo. Yeah. So the fear of having this disease, although it is not yet clear when the disease is there. Yeah, I mean, there is a risk. Maybe there is potentially some sort of like a cholesterol for Alzheimer's disease. Yeah, so this needs a lot of more scientific understanding and, of course, a lot more of education and communication.
Communicated well, yes. And you think, Marjolein?
Yeah, and I think in that sense also thinking about these issues from an ethical perspective is also really, really important.
You want to
also
know.
because you don't want to increase anxiety in people. And I feel at this time it is most important to focus in our communication on the modifiable risk factors that people actually can do something about. And that's there's also still a challenge to reach the less educated people to be more aware of how to improve their brain health.
Yeah. Yes, I see. So one more final question, I think.
Maybe we can think about wrapping up this round, but something that worked quite well with some of the speakers in previous rounds was, imagine you're stuck in an elevator with a minister. You don't have a minute, you have actually less than, you're only going to the 4th floor, so you have about half a minute, but you have the minister's ear. What would be the kind of key ask that you have for that minister? Maybe starting with Lutz.
For their policies.
Yes, the minister with the money in the pocket.
That one.
The point is, increase awareness on emerging symptoms of Alzheimer's disease and medicinalize part of the Alzheimer problem more than it is now.
Thank you. That was the
we're not even on the 4th floor yet.
Not the 3rd floor.
We've hardly
Wonderful.
started our rise.
Our ministers don't have any time because of COVID anymore.
Great impression. So Marjolein, second, yes.
Yeah, I would say invest in psychosocial prevention, I would say, in people with dementia, where we focus on bringing our interventions more timely, more tailored and more accessible to the people that need them.
Oh, wonderful. Yes. So, well then we go into the elevator with Craig. Final one.
Hey, this is very cheesy. I'd say thank you, First Minister, for meeting us 4 years ago. We're doing a great job with Brain Health Scotland. We've a long way to go, and it'd be great to have even more support.
Wow. Yes. Well, I think
that's a direct appeal for Brain Health Scotland. That sounds very good.
Before we go to our next part of the ending part of the conference, there is a question relating to that. Somebody asks, how valuable is prescribing listening to personalized music, to singing or to music or to instruments for people with dementia? I think that you would say that it's healthy, right? All of you?
Yeah, of course.
Exactly. So, thank you so much for being with us. Thank you, Marjolein. Thank you for joining us online. Later on, we will talk to Nora, who's now already there, musical director of a very. Thank you so much. See you hopefully somewhere alive in Bucharest, maybe.
Definitely.
Yeah, wonderful. Thanks.
It'll be nice to meet you in person again very soon.